Okay. Well, welcome to everyone. It's really great to see everybody here virtually, and I'm really looking forward to today's session. And I hope to see your questions and comments in the Whova app. There's definitely some very cool features in the Whova app, so please feel free to comment and ask questions and to answer a couple of the polls that were created in the Whova app. So today we are discussing SDG number 3, good health and well-being. This is a lofty goal here, and so specifically today we will be discussing global health systems. What has changed and what has stayed the same? So just as some context setting for this session today, the pandemic disrupted the way many global nonprofits have operated, especially regarding the flow of personnel and resources. Today, we're going to discuss the shifts in capacity building, funding, and decision-making to staff outside of the US. Some questions we hope to answer are, how have countries adapted to a post-pandemic world? With the caveat that we might not yet be in a post-pandemic world, but we're certainly well into the pandemic and in a new phase of the pandemic. So how have countries adapted to that? And then what is the new normal for our global organizations and the health systems in which we operate? So to help answer some of these big questions, I am joined here by our 3 panelists. And so we have Shripad Desai, who is the Senior Director of Asia and Eurasia Programs at Americares. Welcome. We are also joined by Rotafina Donco, the Mozambique Country Director from VillageReach, and Anurag Taneja, Director of Global iBank Development at SightLife. So welcome to you 3, and my name is KJ Zuniga, and I'm an associate at Linksbridge based here in Seattle. Okay, here we are. So now we can see all of our faces. Welcome to the 3 of you, and thank you so much for agreeing to speak with us here today. I know that it is various times in the evening, so we appreciate you being here with us. So let's get started. Let's jump right into it. And I'm gonna start with a question, the same question to each of you, and we're very interested to hear about each of your organizations. So Shripad, I'd love to start with you. And could you tell us a bit about how your work and relationship with your offices in the United States have changed due to COVID? And what have you learned, and how has your organization been adapting?
Sure. A very good morning, good afternoon, and good evening to all. As a global health-focused relief and development organization, Americares carries out health programs in over 30 countries, and our medical donations reach about 85 countries on an average each year, including United States. So at Americares, we were in the process, I would say, of implementing flexible work schedules and expanding remote work options when the pandemic began. But I must admit that it was underutilized. COVID pandemic actually put us on a fast track. Then I was among a very small percentage of global staff members who participated in HQ meetings remotely. This is pre-pandemic. And the vast majority of the decision makers were based in New York and Connecticut metro area. COVID accelerated our efforts to decentralize our leadership and decision making. And that's one point I want to kind of highlight. When COVID precautions were instituted in March 2020, Americares quickly embraced a remote work environment, which has allowed us to have more geographically diverse workforce with more global perspectives and input in decision making. I'll put 3 points. Today, 2/3 of our 700 plus workforce are citizens of countries outside the continental US. We have global representation on the senior leadership team, including myself, based in Mumbai, India. And third most important point is we have moved away from an expat model of long-term anchor locations. So we currently have locally led offices in Liberia, India, Colombia, Tanzania, Puerto Rico, El Salvador, and the Philippines. And all the team members there are either citizens of the country and or neighboring countries. So these are the three things that I would like to mention here. And I must say that this is a good beginning and we've just begun and there is more to come. Thank you.
Thank you. Yes, it's interesting. And I like how you said that that the pandemic has accelerated what was already beginning at your organization. So thank you. I'm going to move on to Rotafina. So would love to hear from you how your work and relationship with offices in the United States have changed due to COVID and how your organization is adapting.
Okay, thank you so much, KJ, and greetings from Maputo all. I know we have different time zones, so I'll save that and I say greetings from Maputo. Just maybe a quick one to remind everyone that VillageReach, our mission is to transform healthcare delivery to reach everyone, and we are operating against three pillars. One is tech-enabled pathways to primary healthcare. The second one is product to people, and the third one is sustained impact. Whatever we do or we start, we have to make sure that it's either taken by the government or stakeholders, whether private or public. So now going back to how the relationships with the offices have been changed, you know, given the fact that it was an expatriate model, I wouldn't run away so much from Americares the way it is. And just to reinforce and reemphasize the same and say that one of the intended benefits of the COVID pandemic was accelerating what VillageReach had already started before, and that is the need to redefine the meaning of the word global by recognizing and connecting local expertise, acknowledging that communities across the globe have a lot to teach each other, and acknowledging the fact that there is local expertise that can be tapped, and focusing on reinforcing this existing capacity to enhance skills transfer. So if we all know and we agree upon is that the onset of the global pandemic has made it abundantly clear that the countries with the strongest containment and prevention responses for COVID-19 and not always donor countries. Yeah? So I just want to make clear that becoming an organization that is locally and globally connected did not happen overnight. Today, more than 50% of VillageReach organizational and technical leadership is based in Africa, an increase from 28% just 2 years ago. So by changing our leadership structures and growing technical and operational areas in our country offices, we are better positioned to adapt to COVID-19, and we're therefore able to tailor our responses to country-specific needs. I would like to highlight some of the lessons learned, and one was like functional systems are important because they do facilitate the day-to-day activities and communication even during the pandemic. And the second aspect is that local expertise does exist, and organizations need to look for it, nurture and reinforce it. And as I mentioned prior, you know, our aim is to reach at least 80%. Just to say that we have core offices. Mozambique is one of the core office, meaning that we have a complete structure, DRC another one, and Malawi. And we also work with partner organizations and all those who are leading these offices, just like America, it is local expert, people from those countries. Over to you, KJ.
Thank you very much. That's very helpful to understand the context and really emphasizing the local expertise that that VillageReach is leveraging. So thank you. So now I'll move on to Anurag. Would love to hear from you. How your work with and relationship with the U.S. office changed, and how is your organization adapting?
Yeah, thank you, KJ, and thanks a lot for inviting me here. So what I want to say is in some ways similar to what Rotafina and Shripad have said, and a little different as well. So we are also a global health development organization, but we are focused on a niche area of healthcare, which is elimination of corneal blindness by developing the health systems entirely around the value chain, which is prevention to enabling transplant surgery. And I lead IBAN development for them. COVID has been a catalyst for change, and that's how I see it. So one of the most affected sectors has been healthcare, obviously, and the way it has turned out now is that most of these changes have been for good. Our work life and everyone's has seen a lot of change, obviously. Like everyone, initially we thought it was a short-term thing. We just focused on our business continuity plans, thought maybe 3 months, maybe 4 months, and we moved to remote working environment, again thinking that fine, we'll be back in office in July or August, which obviously did not happen. But that is also the time we got this idea that we had to think long-term, and we probably, when the dust has settled, we are not going to be in the same world. And that is where the whole idea of moving decision-making, having that nimbleness of decision-making and moving that decision-making progress from Seattle, which is where our head office is, to our local offices, which primarily has been India. And that happened. And it happened over a course of 12 to 18 months. And right now, all our program leads and decision-making actually happens in the local offices. All our functional support teams are actually, 90% of them are actually in the India office now. And what it has done in terms of lessons is that we have seen that it's a rapidly changing environment the past 24 to 36 months almost. Things change very quickly, and going through the usual hierarchy would have been made the progress a lot slower than what needs to be. It worked for a different time. But we have realized across geographies that having decision-making at a local level actually has worked better for us. We have been able to respond to a changing environment in a much better fashion as compared to what we used to do. And this is something that is working with us. Another thing has been, we started getting into the whole DEI bandwagon. Yes, that was there, but the focus has been not just upon the usual areas of diversity and inclusion you talk about. It has been on diversity of thought. Suddenly, the entire team across wherever in the world they are, there has been a lot of discussion and brainstorming to the extent that at some point we thought, okay, maybe we had too much, but we have got that out. The ideas have come from, quarters you would usually not even think are going to speak about things like that. And we've been able to change. It's not the same organization. It's not the same work environment. And though we still are remote in many ways, but we have moved on to a hybrid sort of environment. And we've sort of found a balance that works for everyone. We also found that people are happier when they are in their native places. So they don't have to be in a certain city for a certain office, and they can always just move a bit here and there, and it works better. So we have I'd say a happier team, a more productive team, and that is something that's the best that's come out of this pandemic. Thank you.
Thank you. Yeah, that's really fascinating to hear. It seems like across the board for all three of you, this has been a catalyst for good. Of course, the pandemic has devastated our world, but the organizations you work for have really found ways to leverage that and really move decision making and focus on the country offices, not just on the US offices as well. So thank you. And I also noted here the emphasis on diversity, equity, and inclusion, and also looking at diversity of thought as well, and expanding beyond maybe what the typical things that we think about in terms of DEI. So thank you for that. So that was helpful in providing some context for your organizations, and very fascinating, a lot of similarities that I'm hearing across the organizations. But let's dig into a little more specifics. So Rotafina, I'm curious about VillageReach, and how did VillageReach's experience with vaccine management and distribution of medical products help during the COVID vaccine process in Mozambique?
Okay, thank you so much. I would like to start maybe by providing the context to say that under normal circumstances, you know, in an ideal world, we would like to have a public health emergency operational center that is working, you know, full-time and operational. Unfortunately, this is not the case for Mozambique, where our public health emergency operational center, it is there, but is not fully operational. It should have been the unit that would have been coordinating everything. Unfortunately, this is not happening during a pandemic. It is situated within the surveillance unit in the public health department of the Ministry of Health, and does not have a lot of autonomy to position itself, to mobilize, liaise with other stakeholders in the government to prepare and respond during a pandemic. So all stakeholders, including the Ministry of Health, recognize this fact. And this is the reason that during the severe phase of COVID-19, that was the third phase of COVID-19, where we had quite huge spikes of the disease and deaths, the Ministry of Health requested VillageReach technical assistance to coordinate the COVID-19 response activities. And the reason was, of course, the lack of a functional or operational PHUC. These gaps were there, and so the Ministry of Health reached out for us to help. So we were therefore able to facilitate the process of the development of the country's caused COVID-19 response plans for 2020 and 2021. So everything that has been implemented in Mozambique, especially with regard to COVID-19 response, VillageReach has a footprint in it. We were just working behind the tables, so that at least this would work. We also co-created with the ministry most of the tools that were used to coordinate the different activities within the different COVID-19 thematic working groups. We came up with like activity, simple tools that the PHUC is supposed to already have it, all the SOPs, and these were lacking, like activity tracker. We were also able to facilitate producing weekly new flashes of the COVID-19 country situation, where people would refer to know how many people were infected, where, how, and what was being done. We also facilitated the integration of vaccines within the classical routes of transport, just to say that, the expanded immunization program in Mozambique is the one that is responsible for all the vaccines logistics. And what really happens is, and we also have the central medical unit for all the other medical products. And what we've seen over the years, and it's that this, even though they are under the Ministry of Health, they do not communicate, they do not work together, they do not plan together. And during COVID-19, it was very important to bring these two units within the government or within the Ministry of Health to talk, to liaise, to plan. So because of this coordination, at least we managed to ensure there was some integration of some of the COVID-19 vaccines within the classical routes of transporting medicine and medical products to the last mile. I wouldn't say it didn't come up with a challenge, because once we were starting to receive vaccines, the vaccines were not as quick and fast as we were hoping for. Of course, the first COVAX system started distributing these ones to the developed countries, of course, and the developing countries were, the last one. So they didn't trickle as we hoped. So this created a challenge. But nevertheless, we managed at least to convene, bring these two parties together that are very important in terms of vaccine planning, logistic planning, and things really worked out because we were able to transport these COVID-19 vaccines till the last mile. We believe that this contributed to a better planning, agility, and of course, communication. We came up with quite a lot of tools, which led to a well-coordinated and successful COVID-19 vaccine campaign in the country. I'm saying this because by September 2022, Mozambique had a COVID-19 vaccine coverage of more than 96.6% of eligible adults over 18 years of age. Compared to the other countries, Mozambique, we had really done okay and well. So we are still conscious that the PHEOC is critical, is key to making sure that coordination happens. We are working very hard with the government to ensure that it is operationalized so that when we get another pandemic, fingers crossed that we won't get any in the near future, that it is operationalized. And we are working with the ministry to make this happen. We also played a very key role, as I said, convening various meetings within the ministry and between the ministries and other stakeholders with regard to supply chain and and logistics for COVID-19. Thank you so much.
Thank you, Rotafina. That's really interesting to hear, and especially how VillageReach truly is a trusted partner in Mozambique for the government and the Ministry of Health, and that important role, not only in the supply chain and logistics, but being that facilitator, that liaison between the different entities at the government level. It's a very important role, and also hearing the vaccination rate in Mozambique, that's much higher than the US. So very, very interesting to hear, and congratulations on all of the work that you've done. So I will, we'll come back to you, Rotafina, in a bit for some follow-up questions, but moving on to Anurag. I'm curious, in the past, SightLife has utilized resources and trainers based in the US to train community health workers and corneal surgeons on eye care. How did this change during COVID?
Thanks, KJ. Yeah, you're right. That's how it used to be when we, first started outside of the US. It was first in India, and then expanded to China, Sub-Saharan Africa, Greater China, and a couple of other countries. So at that time, there was very little capacity in terms of training. There were people who were talented surgeons or community health workers, eye bankers, but couldn't train. So what we used to do was fly in experts from the US primarily for clinical and eye bank training, and from some other regions for training community health workers, need of the hour. However, even before the pandemic, our goal was always to develop training capacity locally. And we had been working for the past 7 odd years to develop this capacity for the oldest programs that we have, eye bank development as well as clinical training. So, and we had already in India, for example, we had already developed 2 training centers for eye banking, and we had several surgeons who were already training inside India and even for regions which were close neighbors like China as well as Nepal. So that's something we had already done. The bigger change that happened during the pandemic, as you could say, as a response, was that we started to think, how can we utilize this time? it became clear that we probably will not be able to have this regular in-person short-term training model for quite a while, for two reasons. One was, of course, we couldn't travel, and second was that we weren't sure what the situation in terms of funds would be when this is over. Eye care has not been that much of a beneficiary compared to others avenues of healthcare. So we started looking for ways to utilize this time. So we started working on the curricula that we already had. They hadn't been touched in years. So we thought, okay, it's a good time to bring those up to speed. And we also worked with our teams, the subject matter experts in Seattle, to actually work on developing the curricula which didn't exist. So these were the ones which the trainers would use. And we also worked with them to develop training guides. And we started scouting for potential trainers. So some who are already in the loop, and we also started looking at developing 4 regional centers within India, with the aim that these centers could also be the training centers for pretty much all of Asia. And this is something we're still working on. What we have completed is that these curricula and these training guides are all finished. We have had online virtual sessions for training of these trainers on how to utilize all this curriculum, all these guides and lesson plans and everything that is also. There's a lot of content which they can utilize. And I'm happy to say that a lot of them have already been used, actually more than we expected right now. So that's a big thing. And the other thing, the big paradigm shift that came was that in healthcare and eye care, there was a thought that you couldn't do it virtually or online or to the usual, because you just can't engage. There are a lot of technical topics which are not possible. This was the thinking. We have realized that if used properly, and that is the key word, using properly, if you use it the way it's intended to be and innovate at the same time, a lot of this training that we used to impart can actually even be managed online. Except you just can't do it the way you would run an in-person training. Like you gather a group of people, give them a lecture or a webinar for a while. That doesn't work. But if you make that into bite-sized learnings, if you really follow that learning principles to the core like it should be, we have seen that skills can be imparted, with some exceptions which I'll talk about. But we have done that. A good example is that we partnered with the Eye Bank Association of India, and we developed a thriving online learning community. So we had already worked for several years in India and in some other countries, and developed talent over here, which could be trainers. So we use this time for them to become trainers, with our experts being completely out of the picture. Usually, even if we do something virtually, it will be experts from SightLife, mostly from the US. But this time we were only facilitators. The entire training was handled by these people that we had worked with to develop as trainers. And we've seen some amazing success. And for the first time, these trainings were available to all eye banks in India. India has almost 800 eye banks. We used to work with some 25 of them. So a lot of the eye banks were just not getting everything that we had done over the years. And this was also open to people from China, Sub-Saharan Africa. I mean, anywhere they could somehow manage English. And we have seen that, that changing. And, it's also helped develop a certain level of international collaboration. So there are ways in which we have seen some institutions from different regions have been able to contribute in ways we had not thought possible. For example, again, iBanking. So National Eye Bank in Hong Kong, they're not big, they are not well known. However, they have absurdly good culture of quality. And that is something we have seen developed. We have seen the journey over the last few years. So we thought, why not? Someone can speak English over there, so why can't they actually talk about this journey as to where they used to be, and they can bring that culture. So it was all about getting that quality culture. And, Shripad would probably understand that culture of quality in healthcare sometimes is not easy when you start looking at some kind of institutions. So we shared that journey, we shared the procedures, how it was done, how others can do it, and it turned out to be the most successful learning module that we had out of the ones we've done in the recent past. So that has what has changed. We have realized that a lot can be done virtually, a lot can be done with local talent. The talent was always there. We just had to give the right push, and the pandemic came by at the right time to somehow provide that push. And the world is opening up. We have seen even funders looking at, okay, there's iBanking talent in India, there's iBanking talent in Nepal. And we actually seeing this, a lot of this talent actually now getting utilized. We are doing a project in Mali, for instance, right now. And this is entirely supported by the team from India and Nepal, with absolutely no input actually coming from US centers. So that is a big change. That is the first time that has ever happened that we've actually taken up a project in an entire country and the US team has not supported at all. So that's the change. That's how things have changed. We will have to go back to a hybrid sort of training model for sure, but I mean, we sure have learned a few things. Thank you.
Thank you. Yeah, that's very, that's great to hear. And especially, and I think it sounds like SightLife as well. I know other organizations really took advantage of the pause to update their, you updated your training and really thought through the curriculum, updating it, adding new modules. And so that's, I think that's an important thing that you did. And then, adapting the training for a virtual environment. And, I think the pendulum's certainly swung to exclusively virtual, and now we will have to move to some sort of hybrid model. But I think getting rid of all of the assumptions of which one is the best or the only way to do things. And then I also just wanted to note, I really appreciated hearing that, SightLife India is now working exclusively with another country without the US involvement. And that's possible. And again, it's just pushing our assumptions of what needs to happen, what the role of the US offices are. And there is an important role, but it doesn't always, but then there's times when SightLife India can take that on themselves. So thank you for sharing that with us. So I'm going to move on to Shripad, and I haven't forgotten about you. So hello. So I'm wondering, what was the impact of COVID on primary care service delivery? And how did nonprofits respond, particularly in India?
Sure. This could be a kind of a flashback to you or to some of our participants, as you must have read in the newspapers and print media. And similar to many countries in the world, COVID-19 surge crippled the health system across India, I must admit. And it happened at two levels. One was at the health center level, as in infrastructure level, and second was at the health worker level. And I'll talk about both in a bit. So when I say health system affected at a health center or an infrastructure level, both at national and local health systems really struggled to keep pace with the need for hospital beds and oxygen supplies. There was a rapid and colossal increase both in outpatient as well as inpatient load, which led to hospitals and ICU facilities being really, really overwhelmed, as you must have heard. There was a shortage of equipment, both protective. So in the first phase, the country faced a shortage of protective equipment in terms of gloves, masks, PPEs, and so on. And in the second wave, we faced a huge shortage of treatment-related, equipment shortage. At one point, you won't believe, but the oxygen demand in country was as high as 6 times than a regular requirement. Now, while health infrastructure or health facilities were struggling there, on the other hand, the healthcare workers in India, as in all countries, I would say, experienced a huge burden, both of work and of mental health. So changed roles, multitasking, increased working hours, increased risk for infections, physical and mental exhaustion had a clear impact on healthcare workers in terms of the burnout. In fact, I would like to quote a report for Mumbai health workers, wherein 24 to 62% of the healthcare workers reported anxiety, about 27 to 50% reported depression, and 15 to 75% reported stress. So when we look at these two aspects, how did it actually on ground affected the primary care service delivery. And here I'm going to talk about not COVID, but the regular primary care service delivery. And if I have to take an example of India's one of the largest metropolitan like Mumbai, context, then it is reported that there was a reduction in registrations for first trimester as well as institutional births. There was a decrease in immunization sessions, particularly during the first wave that we experienced. Tuberculosis, which is so rampant, tuberculosis patients suffered due to lack of availability of centers because many centers were closed, staffs were diverted, there was lack of access due to lockdown in the first wave. And overall, there was 23% reduction in new case registration as far as tuberculosis was concerned. There was 30% reduction at government facilities for three major disorders, which is hypertension, heart diseases, and diabetes. And finally, most importantly, significant reduction in elective surgeries and emergency cases were observed during pandemic. So, this is how the whole focus on COVID and the increased burden led to impact on the primary care. Now, answering the second part, luckily, nonprofits like us, including Americares, were there to play a supportive role, I would say, shoulder to shoulder with the government infrastructure, facilities, and service delivery. For example, Americares focused on 4 areas. One was preparing the communities because that was a very, very important aspect that needed to be addressed. Second was primary care delivery. When everybody was focusing on COVID, there were so many people who were suffering with non-COVID disorders, and there was a need for kind of addressing that population. Third was protecting the healthcare workers, something both Anurag and Rotafina mentioned. And finally, strengthening the COVID facilities. So America's classically focused on all the 4 pillars, if you will. When it came to community sensitization and education, our teams both we run huge mobile health clinic program and community-based health programs where we focused our attention on educating and sensitizing the communities on COVID appropriate behavior, be it masking, hand washing, social distancing, sanitation, and hygiene. Second, like Rotafina mentioned, we also focused on addressing the vaccine hesitancy and encouraging people to come forward and vaccinate themselves. In fact, in the second phase, America's actually got into conducting community camps, and we were able to vaccinate more than 30,000 individuals for COVID. In terms of primary care service delivery, as I mentioned, even the general practitioner, which is the first primary care physician in India, they were addressing only the COVID population and nobody else. So primary care was one of the major, unattended care, particularly for, chronic care patients or NCDs and so on. So America's mobile health clinic program, which runs in 6 states across the country, adopted a telehealth model in the first phase where there was complete lockdown. So during the lockdown, we quickly, adopted to a telehealth model because we had the patient database and we were able to offer teleconsultations, telemedications. We connected the patients to the nearest pharmacy, and the continuity of care, as they say, particularly chronic care patients, was offered. And this model then, after the lockdown was continued, and America has made sure that more than 10,000 people were able to receive the primary care during this time where they had none, so to say. The third aspect that I spoke about was protecting primary health workers, and they needed the protective gear. So America has mobilized across the country, roughly about 20 states, about 4.7 million units of primary care protective equipment, be it PPE, gloves, masks, and so on and so forth. But the most important piece that I want to talk about is about the health system strengthening, which happened in the second wave of COVID, because as we know, the surge was so high that the facilities that I mentioned were not able to cope up with the need for equipment, need for oxygen. So that's where we partnered with various state governments. In fact, we supported about 240 plus dedicated COVID centers across 20 plus states in India, which actually meant procurement and installation, training, capacity building of healthcare workers for about 6,000 plus equipment across. And this also was supported then by making sure that 4,000 plus units of oxygen concentrators, setting up ICU beds and oxygen plants. So this is how we were able to, I would say, support, substantiate, and contribute to the struggle that both the communities as well as the government health system infrastructure was experiencing. Thank you.
Thank you. Yes, it's important to remember the primary care that was affected during this pandemic, and I particularly appreciate the emphasis that Americares and other nonprofits in India were focused on, which is the people. You know, a health system is made up of people, both the practitioners, the healthcare workers, as well as, you know, folks getting treated. And so the focus on protecting them, acknowledging the stress and anxiety that this caused, which I think was a pretty universal issue for healthcare workers across the world, that unfortunately is still an issue today. I know, at least here in the US, the anxiety, stress and depression. So thank you for highlighting that, and for highlighting the impact on primary health care, because this COVID wasn't the only thing happening in the world. You know, everything else, the regular health services and needs were also present and continue to be present. So thank you for sharing that. So I'm actually going to go back to Anurag for my next question. And you touched on this a little bit, but I'm really curious now that mobility is almost back to normal. I'm wondering, you know, do you see the same level of engagement for these virtual trainings and you know, and overall engagement, or what do you see now and in the future?
Well, yeah, that's an interesting question. Well, you know, in the area that we serve, there were always going to be some avenues where online training either was not indicated or, you know, just not enough on its own. So while engagement in these online sessions still remains pretty good, however, we see opportunities where we must either get back to engaging face-to-face or adopt you know, some level of a hybrid model. You know, I'm using the word hybrid a lot. You know, a case in point could be, so we do these things, we did quality audits for iBanks. Now, because we couldn't travel, there were no quality audits because we couldn't go there. So we created, and we were actually the front runners in that, we created a brand new system of remote audits. An audit is all about, you know, mostly about a lot of document checking and then, you know, observing processes and interviews and so on. So we realized that if we could handle it, it could be managed in a virtual remote model. And while we spent months developing that, it did seem to work. And actually, the partners that we worked with are quite appreciative of how it was and how well it actually went. And the technology worked. I think all the leaps that we made in technology really came in handy, and it worked. The one problem with this model was that it was very time consuming. Versus just going and looking at a bunch of documents. Now, unfortunately, our bank staff was forced to scan a lot of documents, to write about them, to label them, you know, indexing and everything that they had to do and send it to us. We would review, send it back, and then it comes back and so on. It became, instead of a 2-day process, it became a weeks-long process. While that was okay when there was not enough work for these techs and other iBankers to do, but now that things are back to normal, fingers crossed again, they have the usual work. They just don't have time to do all that. So we realized that what we're working during these COVID times is not going to work now. But that doesn't mean that we have to go back exactly the way we were doing things. So there are lessons from there. We realized that there were some portions of the audit which actually worked better in a remote mode. So, you know, interviews, for example, doesn't matter if you're interviewing the medical director, you can do it online as well, because one of the reasons we used to struggle was finding time from the medical director, which was always a hassle. So here you can just choose any time that works and get that out of the way. There's some process related work which can be easily handled online if you just keep sending documents through several weeks instead of, you know, getting them all at once. So now we've worked on a hybrid model where instead of 2 auditors, we can manage with 1. Instead of 2 days, the audit becomes a 1-day audit. So that reduces the cost, it reduces the burden on the auditor. It also reduces the burden on the partner who's getting audited. And we're still ensuring the same processes, exactly the same processes that we had. So we got these learnings from where they were. from the COVID time, and we were able to adapt. So that's one. Another example could be clinical training, surgeon training. So we had to move virtual at that time. Every training that we had planned was cancelled because, well, surgeons, right? You can't just train them virtually. We tried. We really tried to get as much of that online. And while you could get star surgeons to, show their surgeries live online, you can't have that face-to-face engagement. You can't have those, the same kind of questions and answers and hand-holding and hand-eye coordination training and everything that comes with it. So, however, we did realize that some of that, a portion of that could actually still be done virtually. So we used to have a 3-month training of surgeons who were practicing cataracts only to move them to a cornea practice. This was, we used to do it in collaboration with a couple of hospitals in India. We realized after a complete evaluation of the coursework that quite a bit of that could be converted into a self-paced online learning. So the 3-month course has now become a 2-month in-person course. And the first month, all of that, all the usual didactics has now moved to a self-paced learning environment, which is all available online. So surgeons can do it at their own pace, whether it's 1 month or 3 months or 6 months. When they pass all of that, that is when they have to travel for 2 months, which means they don't have to spend too much time away from the practices because they already have practices, and we are still able to get the same results. So things, virtual is going to be there. Earlier, it just wasn't there. When you think about, training, especially these hand-eye coordination jobs, which is eye-band technicians or whether it is surgeons, but you could always pick up the best from what we have learned virtually and get it to an environment where, we are able to get that done. And we're also able to satisfy the need for a face-to-face interaction, which, as we are learning more and more, that is something people really want to do. After all, we are social animals. So, in a way, we're still learning. We continue to adapt. I'm sure this is what we're doing right now is not the end, and probably with time we're going to change even more and hopefully in a better direction. Thank you.
Thank you. Yes, it's I think it's important to it sounds like you realized that some things could be done virtually, and also some things were better done virtually. But as with anything, there are things that just can't be done virtually. But again, I think it sounds like this pandemic really forced you to just put away the assumptions and see what worked, what didn't work. And then hopefully moving forward, it's going to be that hybrid model that really encourages efficiencies when it can be virtual, and then focusing on what's needed to be in person. So thank you for sharing that. Rotafina, back to you, a question for you. So earlier you were telling us about VillageReach's, the great work you were doing in coordination with the government for the COVID response. But I'm wondering if you could also then tell us a little bit about the challenges you faced during the pandemic and how you overcame them.
Okay, thanks, KJ. I couldn't help but, wonder how similar, these challenges were when Shripad was talking, about some of the same, challenges in India. And he mentioned about vaccine hesitancy. It was the same, of course, in Mozambique at the beginning, but definitely we overcame that by making sure we provided communication, information all the time for the people to understand and to know exactly what was going on. He also mentioned about, the lack of PPE, definitely at a certain point due to the fact that, of the supply chain and logistics, everything had stopped, even transportation. So things were really taking time to, to travel and to be brought to Mozambique. So this also affected the timeliness and the availability of vaccines when we really needed these vaccines, And the truth be told, we were of course the last one in the chain, and that did not help. I know that I'm re-emphasizing this, but that was actually the reality. But thanks God, we got the vaccines. We had a very good coordination mechanism with all the donors, including Gavi, and we were able, USAID and others, we all worked together to make sure that at least everything worked and functioned in terms of logistics, and underlining some of the bottlenecks. And this, despite the unavailability, whenever we got those vaccines, we were able at least to transport to the last mile, so that at least it could get to people's arms. So that was very important. And so I would emphasize one of the things that despite these challenges, planning coordination was spot on, and this really facilitated the process. And another important challenge that I want to highlight is the fear of the unknown. At first, people were very curious. There were people are also very superstitious in my country, of course, in Mozambique, and they were sort of like skeptical at first, about this COVID-19, and we had to do a lot of sensitization, and it was joint work, government campaigning, also VillageReach facilitating and helping the government to reinforce some of the, like the hotline that the government has, to make sure that at least it was 24 hours shift. We really had to coordinate that and make sure that at least some features were also added to make sure that at least people, the night shifters would also handle the traffic. So these are some of the, these are some of the things that we undertook, but to be honest, I wouldn't say that this was, we only undertook it. It was group teamwork, I know, because we had every week, those coordination meetings to only talk about COVID, to talk about the challenges, data challenges, logistical challenges, who was doing what, how could we assist, how could that be helped? So that really mitigated these challenges. And another thing that I'd also mentioned earlier on was the challenge of integration. We know that, as I had said earlier, we have a central medical unit that is in charge of transporting medication and supply chain to the last mile. As VillageReach, we provide technical assistance in this regard as well. And at the same time, we work with the expanded immunization program, EPI, to make sure that vaccines are also organized, so that convening, bringing these two entities together so that at least vaccines could be integrated into the classical model, of supply chain of transporting medication, including vaccines, to the last mile. That was, for us, that was very key. And it's good that it is still taking on. I know we have our challenges, but this definitely, we open the doors, and we hope that this will continue. And another challenge, which I also know that it's across the globe, of course, due to the fear of the unknown, due to the fear that you might go to the health facilities, and in the health facilities, that's where COVID-19 is. All the other activities came to a halt, especially at the, at the health facilities. Everybody, all the efforts, we were just, it was just directed to COVID-19 response, and in this regard, some of the other activities were neglected. Of course, not neglected because we wanted to neglect, but we had an urgent, response to tend to. So they sort of like, even, our work as VillageReach, some of our deliverables were delayed because we had to divert some of our attention to at least COVID-19 response. And again, this really, some of the people who had maybe some underlying conditions. I know they also suffered a lot because they were afraid to go to the health facilities to get the care that they wanted, because that's where you will get COVID. And, you know, things deteriorated in some instances. And another last thing that I just wanted to highlight is there was a decline of routine vaccine uptake due to that fear of going to the health facilities. And this was not really good, because right now, as I speak, we are now facing, you know, the impact of that, reduced vaccine uptake, especially for children, because we are now having another emergency, and that is polio, where, you know, because of the neglect, because of the fear. So we have world polio in Mozambique, and we have at least 8 world polio cases and others derived from vaccine. And we are working against around the clock to make sure that this is also stopped, so that it doesn't spread so much to create paralysis, especially in children. So we are in this situation. And this is also an aftermath of COVID-19, because the focus was on COVID-19, everything including vaccine, and also the fear of going to the health facilities. Then we have now children who are 0 dose. They have not been vaccinated, or there was no good follow-up of vaccines, you know, of already vaccinated children. They didn't finalize, they didn't follow up, and we are getting those repercussions. In addition to polio, we are facing measles, outbreak in Mozambique. And this, that is the bad side of COVID-19. Luckily, at least we learned from the COVID response that good planning, communication, agility, you come together and you do everything that you are supposed to do. You can help curb whatever disease you want. Unfortunately, Mozambique is a country that is always having outbreaks. It's having disasters because it's from cyclone, and then we have cholera. Right now, after COVID, because of reduced vaccine update, we are also having vaccine related, diseases that can be vaccine prevented, surging up like polio and measles. So in a nutshell, these are some of the challenges that we had and some of the measures that we took to overcome them. And Shripad really made my work easier, because he actually mentioned and highlighted some of them, given the fact that they were, they were similar across the globe. And yes, this is where we are. And over to you, KJ. Thank you.
Thank you, Rotafina. That was a lot of challenges that I think people in any country can relate to. It really rang true from what I've seen here in the US, as well as what I've heard from colleagues around the world. So unfortunately, we're all facing similar challenges, but fortunately, perhaps we can support one another and learn from one another. So thank you for sharing that. And yeah, just wanted to highlight, one of the issues around access, that's a little further out of your control, getting PPE into the country, getting the vaccines into the country. But once it was in the country, VillageReach and others really focused on that distribution. So I think that's an important piece. And then, this idea of the fear of the unknown is a universal feeling, I think specifically related to COVID, but also to, some health services and new products in general that can happen. And so I think, and then just hearing about primary care services, routine immunization being affected has unfortunately been a universal experience as well. So it's important. I'm glad that both you and Shripad highlighted those important challenges. So I'm I have one last question for you, Shripad, before we get to our final wrap-up questions for everybody. But Shripad, I'm curious your thoughts on what you see as the new normal for health services in India, and this renewed focus on the resilience of health systems.
Sure. I must admit here that COVID has taught all of us that there is nothing like normal. Rather, change is the only constant. Having said that, there are certain pluses, I would say, which are good from good outcomes of COVID, if you will. I would like to highlight maybe 3 for the audience. One, of course, in terms of at the health facility, the new normal, if I have to use the terminology that you have used, is high focus on infection prevention and control. I think one positive outcome of COVID is that from a subcenter, which is the first point of contact for any community person in India for healthcare, to the tertiary care hospital, awareness, sensitivity, and focus on infection control, prevention and control has gone up. So, before COVID, access to sanitization at health facilities, be it a hand wash station, sanitizer, even use of protective gear like mask or PPE when needed, or gloves, etc., would have been a question mark. But I'm happy to mention that that's something that we are finding being a new normal here, even despite COVID not being there. I mean, that rampant. Apologies. The spacing, social distancing norm, the information, IEC material, improved ventilation. Some of those pieces have stayed back at the health center. So we are able to clearly distinguish between a health center pre and post from infection prevention control perspective. The second thing that I see new normal, and I think Anurag spoke so much on that, was capacity building of healthcare workers. So this is something that we are seeing is going to be the new normal, be it infection prevention control or otherwise, and in that use of technology. I think the use of technology in capacity building for healthcare workers is going to be is here and is here to stay, I would say. So we are now seeing, like Anurag mentioned, more and more virtual sessions, hybrid sessions rather than classroom sessions across the hierarchy of healthcare workers. I want to mention here that Americares in 2022 has launched a free, perhaps world's first free online platform for education of nurses on infection prevention control and antimicrobial resistance in 6 Indian languages. This is almost like a Coursera for the Indian nurses. They can take these courses, 6 certificate courses, which are certified by and credit hours by Trained Nurses Association of India. About 100,000 plus practicing nurses in India from various languages now can go online and undertake these certification courses and claim credit hours. So I think this is where the new normal, if you will, is kind of moving. The third piece that I want to talk about is more from community perspective. So I spoke about the health centers, I spoke about the healthcare workers, and the third piece that I want to highlight is on from the community perspective or a disease perspective or a disorder perspective is increased focus on mental health. I think if one positive outcome that I have to highlight here, I would say mental health. So, mental health, as we already know, is projected to be one of the leading cause of morbidity and mortality. I think mental health awareness, sensitivity across, not only in health system, even in schools, colleges, communities is going up very, very rapidly. And of course, a lot of awareness is happening there, in that sense. I want to mention here a capacity building program that we, like Americares and Tata Institute of Social Sciences, which is one of the world's leading social institute, have undertaken. We have taken on us to have at least one trained mental health and psychosocial support worker in each district of India by 2025. India has got about 750 plus, districts, and this we plan to do by training a healthcare worker in a partner non-profit organization. So what we are trying to do here is identify like-minded non-profit organizations and building their own capacity to deliver mental health in those, the geographies that they operate in. And that's one of the programs that we have launched. We already have 80 of them operating in 45 districts across 11 states of India. And our endeavor is to kind of multiply. One in every district is, I would say, a very minimal, ambition or a starting point. The potential, given the geography and the population of India, the potential is huge, and that's where I would like to see the movement. I would like to see more partners, both from donor fraternity, academia, as well as non-profit partners to joining in. I think you asked about health system resilience, and here I would like to, particularly our audience, I would like to highlight on the way government of India is looking at the 5 pillars of health system. And I think here I'm going to talk some key points so our audience can kind of think as to how India or government of India or Ministry of Health is changing. And when I talk of 5, the pillars, basically governance, financing, health workforce, technology, and service delivery. So in terms of governance, the Indian government aims to increase the healthcare spending to 2.5% of GDP by 2025. GDP is gross domestic product, up from below 1% in 2021. I think this is a very, very massive commitment that the government is putting on table. And we all know, of course, when and I'm not saying that by saying 2.5%, the government has already done it, but by the government expressing that they would like to more than double it up itself is a positive outcome, I would say, in terms of COVID. Second, government's efforts in achieving universal health coverage, like health for all, through Ayushman Bharat. Ayushman Bharat means Long Live India. So there is a program that the government of India has launched, and it's now getting accelerated post-COVID, particularly, wherein a common man can get a health insurance worth 500,000 Indian rupees, and they can avail any surgery or any procedure per se in private hospital as well. So they don't have to depend only on government hospitals. They can expand them. I mean, they can reach out to private hospitals. So that's something that helps both in from the policy perspective as well as finance perspective. In terms of health workforce, government of India again is very, very much, I would say, focused, and has recently launched integrated government online training portal. So what Anurag mentioned, what I mentioned, as non-profit, the government of India certainly recognizes that, and a portal allows the paramedics, doctors, nurses, technicians, ANMs to build their capacity on various aspects. So that's something really very, very interesting step, I would say, from the government perspective. Third, in terms of technology, post-COVID, the government of India and Ministry of Health have actually opened up for telemedicine. So earlier, the registered medical practitioners were not allowed to use telemedicine, but or I would say telemedicine was not prevalent. Today, there is a ruling, there is a new guideline wherein a general practitioner can use telemedicine, and that's, I think, is a very, very bold step for the government. In fact, government has launched a national digital health mission, so that encompasses basically telemedicine, health IDs. Each one of us have a health ID today. Health records, my ID can have all my personal private health records. So in case of an emergency, if I'm not in my regular healthcare provider, but I have that card, the healthcare provider can access, which is a really bold step, along with e-pharmacy. And I want to mention here, when I talk of technology, about in October 2022, World Mental Health Day is celebrated on 10th October. So the government of India has launched a 24/7 tele-mental health service helpline in regional languages, which serves 20 states across India. So, these are some of the initiatives. Last but not the least is about health service delivery. So government of India was already focused on upgrading the primary health services to health and wellness centers. But I would say post-COVID, that effort has gone up, where the focus is on expanding service delivery, diagnostics, wellness, NCD, telemedicine, even yoga to be brought in into the continuum of care. And the idea is to upgrade the primary health centers to health and wellness center, so that, that is able to offer comprehensive care. And here I want to mention, before I end, this Americares is kind of committed for this health and wellness center program. Currently, we are working with about 8 different state governments to help them upgrade the facilities, both in terms of infrastructure, health worker capacity, and the community connect, because at the end of the day, it's important that community is connected back to it. So to summarize, yes, there are a few normals, and I would say the biggest gain, I would say, in terms of health system strengthening, is the government taking certain bold initiatives to accelerate the system strengthening. Thank you, KJ.
Thank you. Yes, that's thank you so much for that. And you had a lot of really great points there. And one that I did want to highlight is that mental health is health. and I appreciate you mentioning that here. So thank you so much for that. And as normal as we can predict the future to be, I think you helped us understand what the new normal might be like. So we just have a couple minutes. And so I have one last question for each of you, and I'm hoping you can just give a very quick answer so that we can get to all three of you. But Anurag, I'm going to start with you. We've heard a lot from each of you, but what is one or two benefits that you hope will stay in place due to COVID?
Okay, I'll be quick because Shripad's done most of my work. So everything that Shripad said, whether it's infection control, mental health, capacity building, all of that, and that would have been the top of my answer. Something Shripad also talked about was how the government has really taken it up. So I think that, the pandemic sort of woke up the government. And we have seen a level of intent and also discipline of execution, which you don't usually see in governments. To the extent we've never seen before. So the government has responded to a request to policy changes with a speed which was spooky at times. For example, when it came to developing standards for iBanking, for the COVID time, it took us 3 weeks. When we had to do a similar thing last time, it took us 7 years. So that's the difference that a global pandemic can bring about in the way a government functions. And while we understand this kind of vigor may not remain, we certainly hope that this kind of intent and this discipline of execution stays with the government, so that we can get a lot more done in a much shorter time. Thank you.
Thank you. And Shripad, I'll go back to you briefly. 30 seconds. What's the one thing you hope continues?
More personal. So I think I feel that when I say personal, as an individual, I feel the possibility to work, contribute, and participate from anywhere, anytime, as in the remote workforce, I think is going to stay here. And it not only, across the spectrum, I feel that's one thing that's going to stay, and that's going to explode and expand our horizons.
Thank you. And then Rotafina, we'll end with you. What is the one benefit you hope will stay?
Okay, so one of the benefits that I think will help stay is that one of, locally accelerating our localization agenda. I've seen that in most of all the organizations here represented, they talked about that. And I know that this is a very positive impact from COVID-19. And I'm hoping that definitely it will be here to stay, in order at least to make sure that at least we have local skills strengthened, and we have also local expertise on the ground. Thank you.
Thank you. Thank you all for this wonderful conversation. And thank you so much to the three of you for your insights and your candid answers to this big topic. So thank you so much, and I look forward to seeing you in the future, hopefully in person one day.